All right, we're live.
All right, thank you. We're back after break. Jen, why don't we put the bill up and we'll go through it as we thought before at the 2,000-foot level. And then if anyone has questions, make sure you interrupt, stop, ask questions so we can make sure everything's covered.
And I did just send the new version to for editing while we are discussing it.
Okay.
Recognizing that you are looking to finish it up. Okay, so the first section, the first main section, but made up of many sections, is the one that is extending many of the provisions from Act 91 as amended by Act 140, both from 2020. So moving these dates out to 2022, many of them had been set at March 31st, 2021. So here we have the flexibility, AHS flexibility around provider sustainability, the protections for non-healthcare professional employees, compliance flexibility with AHS rules. So as you can see, moving these all from March 31st to 2021 to March 31st, 2022. This next one is the sectioning is off. The Medicaid and health insurer provider enrollment and credentialing, and that had actually been set at a different date. That was at the last to expire of a number of different things. I'm trying to fix the spacing. All right, put you back up. And so we didn't need some language that went along with that. Prescription drugs, or maintenance medications and early refills. This one went from June 30th to March 31st of next year. The buprenorphine renewals without an office visit. Potential for reimbursement of facilities for their bed hold days. Then we have the regulation of professions by OPR and Board of Medical Practice. So you made a few changes here. You moved out the date, but you also, for someone who is licensed somewhere else to be able to provide services here, you also allowed specifically people who wanted to be volunteer members of the Medical Reserve Corps or to work on the staff of an FQHC. So that all carries through. You added language requiring the Board of Medical Practice and OPR to provide notice of the March 31st expiration date to the people who are providing services in Vermont under this authority. Change the terminology from retired healthcare professionals to inactive licensees of the Board of Medical Practice and OPR. Made some conforming changes there. Also extended this to include the volunteer members of the Medical Reserve Corps and people working on the staff of an FQHC. And again, required OPR and the Board of Medical Practice to provide notice when this is going to expire. And change the terminology here again on people who had been, instead of retired, inactive longer. Then we have the authority for the director of OPR and the executive director of the Board of Medical Practice to take action on behalf of their respective boards through March 31st, 2022, if the boards can't convene a quorum. We have the emergency regulatory orders that the director of OPR and the commissioner of health can issue, again, through March 31st of next year. Then we get to the telehealth piece. And so this is what I just split out. So we have until March 31st, 2022, the potential to waive the HIPAA compliant connection. But then we have as a new subsection B, notwithstanding again, those same provisions, until 60 days following a declared state of emergency in Vermont as a result of COVID-19, a healthcare provider shall not be required to obtain and document, and then we go into the rest of the language, patient's oral or written informed consent for the use of telemedicine or store and forward, if obtaining or documenting that consent or both is not practicable under the circumstances. So this one again has a just different timing than the March 31st, 2022. This is until 60 days following the declared state of emergency in Vermont. Section 2 is similar extensions, but they had been added in Act 140. They had not been in Act 91. This is allowing the Board of Medical Practice to issue a temporary license to someone who is licensed in another state, and this would extend through March 31st, 2022. Their ability to practice here would be until not later than April 1st. So just moving everything out a date, everything out a year, and making some kind of conforming languages around the physician assistant specifically to reflect the act that was passed last year on their licensure. Then we have the Dfr Emergency Rulemaking. So again, you extended these dates out. This one should actually be March 31st. So,
so Jen, I actually had caught that when I looked at the bill when you sent it to me, and then I forgot. So you caught it. That's good.
Well,
thanks.
yes, good. Between the two of us, somebody got it.
Yeah, we got it. Okay, good.
So this one is going from June 30th and July 1st of this year until the corresponding dates next March and April. So kind of authority through March 31st, and it expires at midnight on April 1st. So this has separated out, again, those two pieces. We have the expansion of coverage for and waiving or limiting cost sharing requirements around COVID-19 diagnosis, treatment, and prevention, and also making changes to health insurance deductibles for prescription drugs to the extent allowed under federal law. So those are going to be treated this one way, where they last until March 31st, 2022. And then we struck out the audio only piece that we deal with in the next group of sections. So then section 4 gets into the audio only telephone. This is again the insurance piece to start. So we have the definitions. Requires a health insurance plan to provide coverage for all medically necessary, clinically appropriate services delivered remotely by audio only telephone to the same extent they'd be covered if they were provided in person. It allows for cost sharing in the form of deductible co-insurance or co-payment, as long as it doesn't exceed what would apply for an in-person consultation. And here's the language: not requiring the existing relationship with a patient in order to be reimbursed. But again, some of that falls under what is clinically appropriate. Section 5 is the provider side. So it allows a healthcare provider to deliver healthcare services to a patient using audio only telephone if the patient wants that and it's clinically appropriate to do so. Requires the provider to comply with any training requirements from their licensing boards. Requires documentation of the patient's informed consent, the reason or reasons that the provider determined it was clinically appropriate to use audio only telephone, and put that in their medical record. A provider can't require a patient to receive healthcare services by audio only telephone if the patient doesn't want to, and it requires providers to deliver care that is timely and complies with contractual requirements, and they can't delay care unnecessarily if the patient wants an in-person visit or telemedicine instead of audio only telephone. Then we have the informed consent. So the provider would obtain and document the patient's oral or written informed consent prior to the appointment or at the start of the appointment, but before delivering any billable service. Must be in accordance with Vermont and national policies and guidelines, and include in language patients can easily understand, that the patient is entitled to choose to receive services by audio only telephone, in person, or through telemedicine, to the extent clinically appropriate, that this audio only visit does not preclude the patient from receiving services in person or through telemedicine at a later date. I'm going through this in more detail because we're getting to some of the new stuff. An explanation of the opportunities and limitations of delivering services and receiving services through audio only telephone, informing the patient of the presence of anyone else will be listening or participating and getting permission for that, whether the services would be billed to the patient's insurance plan if delivered by audio-only telephone, and what it might mean for the patient's out-of-pocket exposure. And finally, informing the patient that not all audio-only healthcare services are covered by all health plans. For ongoing audio-only telephone, the provider only has to get the consent at the first episode of care. If the patient provides the oral informed consent, the provider must offer them a written copy of the informed consent. And you don't have to get informed consent in a medical emergency. This allows the provider to use a single informed consent form for all telehealth modalities as long as it complies with requirements. Prohibits a provider or patient from creating or causing to be created a recording of the telephone consultation, and it prohibits audio-only telephone from being used in certain mental health situations, psychiatric situations. Then we have the audio-only telephone billing data collection report language. So this is, the first part is by July 1st of this year, DFR, in consultation with others, would determine the appropriate codes or modifiers or both to be used by providers and insurers, including Medicaid, to the extent permitted by CMS. In the billing of and payment for healthcare services delivered using audio-only telephone, in order to allow for, and here's our now streamlined list, consistent data collection, identify appropriate codes for services that do not have in-person equivalents, and minimize the administrative burden on providers. To the extent possible, the use of codes or modifiers or both will be done in a manner that allows the data to be identified in VCures. Not later than January 1st, 2022, all Vermont licensed healthcare providers and health insurers offering major medical health insurance plans in Vermont would use those codes and modifiers when delivering services by audio-only telephone. Vermont Medicaid would participate to the extent allowed by CMS. Then we get to your report. On or before December 1st, 2023, DFR, VPQHC, and to the extent VCures data are available, Vermont Care Board would present information to this committee and Senate Health and Welfare, to House Healthcare on the use of audio-only telephone services in Vermont during calendar year 22. The department would consult with interested stakeholders in order to include in its presentation information on utilization, quality of care, patient satisfaction, the impacts of the coverage on healthcare costs and on access to healthcare services, and how best to incorporate audio-only telephone services into value-based payments. Then we get to the audio-only reimbursements for plan years 22, 23, and 24. You'll see new language in here. Requires DFR in consultation with others to determine the amounts that health insurance plans must reimburse healthcare providers for delivering healthcare services by audio-only telephone during plan years 2022, 2023, and 2024. There's the new language. In determining the reimbursement amounts, the department shall seek to find a reasonable balance between the cost to patients and the healthcare system and reimbursement amounts that do not discourage healthcare providers from delivering medically necessary, clinically appropriate healthcare services by audio-only telephone. We'll pause there and see if that fits the need. Great.
That looks good, Jen. Thank you.
Great. Sure. And it allows the department, again, to determine different reimbursement amounts for different types of services and to modify the rates that will apply in different plan years as appropriate, but to finalize its determinations not later than April 1st for plan years after 2022. Section 8 is the telephone triage services, and this allows DFR to consider adopting and have the authority to adopt emergency rules to address health insurance coverage of and reimbursement for telephone calls used to determine whether an office visit or other service is needed. And those emergency rules would remain in effect until not later than April 1st, 2022. So that kind of continues on that idea of the telephone triage piece that we took out of the earlier section. Then we have this language in the telemedicine insurance coverage saying reimbursement parity is not required if the insurer and provider enter into a value-based contract for healthcare services that includes telemedicine and store and forward. Then we get out of that and into advanced directives and the COVID-19 state of emergency with the remote witnesses and explainers. This moves out the language from for an additional year from June 30th, 2021 to June 30th, 2020. I'm sorry, from June 15th, 2020. All right, sorry, confusing myself. So June 30th, 2021 to June 30th, 2022, but it's for a longer period. So it's moving out the end of that period. And this is the time period during which an advance directive can be witnessed in a different form than under our regular advance directive statutes. And similar date extension for a remote explainer. So the remote witnesses and remote explainer language just getting moved out a year. And then we have the immunization registry. You had asked for the language in here for context. So there's not a lot of, nothing happens new until further down here. And this allows Department of Health to provide confidential registry information on the immunization registry to the Vermont Health Information Exchange, so that that information can be accessible to providers who are treating patients and using electronic health records and that are accessible through the information exchange, and carries forward the same written agreement requirement prior to releasing confidential information, carries forward that same written agreement language about keeping identifying information confidential and privileged that applies to the other recipients. So I think there are already data use agreements with the Vermont Health Information Exchange, but this keeps the provisions consistent for all recipients. And the act would take effect on passage.
Okay, questions for Jen? The language solves the problem, Senator Hardy? The Hardy sentence?
I don't know if I want it to be known as the Hardy sentence.
Yeah,
I was
well, I'm just kidding.
attempting to find a balance that might make, as I said, some of our friends in the House feel a little better.
Yeah.
So thank you. Thank you,
Okay.
Jen. It's a good sentence.
Great.
All right, any other concerns, questions, comments on the bill as it currently exists? Good? Okay. Yes, so, and I did share a copy of the bill with Representative Lippert and his committee. So I guess the question is, would you like to vote on the bill today or hold it over one more day and come back very quickly tomorrow and entertain a vote? And the reason I'm asking, even considering holding it over, is simply to give House Healthcare an opportunity to review the bill. Now, I don't know whether they're going to do that together or not, but I will reach out.
And I
Jen,
am
do
just
you
going to
know?
make one change in the statement of purpose to describe that describes the bill. I didn't update the audio only piece in there, so it was still reflecting the earlier version.
Yeah, that's pretty important.
I do not know. I do not know if they are planning to review it. I have not been scheduled in the committee.
All right.
Today.
So it is a committee bill, so it's our bill, and we can vote it. What did we named it? Hold on. Yes, the regulatory flexibility bill.
Yep.
Okay. For COVID regulatory flexibility.
Yes, and we could add on to the end and coverage of audio only telephone services or something like that.
Let's do that. Senator Hardy.
I think if everyone's ready, we should vote it today, given everything else we have on our schedule this week.
Anybody else? Either way is fine. I think I'd like to report the bill, so I'm happy putting it off, but I'm happy also voting on it. It's up to the committee. All right. Jen, will we have a clean copy today then?
You will. As soon as I get it back from the editors, I'll make whatever changes they have found. And yes, and then Madam Chair, you and I need to communicate with drafting operations and
With
maybe
who?
with the Senate Secretary's office.
Oh, yeah.
We have to,
with-
we have
with
to
sec-
say it's the right version, and it's our remote committee bills turn-in process. Just
Right.
different.
Okay. Okay, so committee, is there an interest in voting this at this time? All right. I would entertain a motion then. As long as the clerk is ready.
Okay. I move that we vote on the COVID-19 regulatory flexibility bill as decided on by the committee.
Okay.
And let's make it 6.2 because it'll be a little bit
Okay.
by the
Draft
time I've made
6.2.
these.
Okay.
And for clarification, Jen, does this have an S number? I know it's 6.
Not yet.
Not yet.
It's
Okay,
still
so I don't-
because it's a committee bill. It's still known by its draft request number of 21-0729.
729. Okay. So
Okay, let's see if there's any discussion or further discussion on the bill. Nope. Okay,
okay, so this time, Senator Lyons, if you'd like, I'll proceed.
absolutely, go right ahead.
All right, thank you. So as clerk of Senate Health and Welfare, I'll call the question for proposed bill 21-0729 in draft form of 6.2. Starting with myself as a yes vote. Senator Hardy,
Yes,
Senator Hooker,
Yes.
Senator Cummings,
Yes.
Senator Lyons.
Yes. Okay.
Let the record show that it's a 5-0-0 vote in the affirmative.
All right, excellent, thank you. So Jen, as soon as we have that clean copy, we can get it to the Secretary Bloomer and
I think we just have to get it to start. We just have to get it to drafting operations.
okay.
I have to,
Okay, so
look at-
yeah, so that, right, it's a committee bill.
right.
After that, after drafting and operations, does it then go to the Senate?
Drafting operations will prepare it for introduction and get it to the Senate Secretary. I think then you also need to let the Senate Secretary's office know who will be reporting.
Okay, I'll do that. And then I guess my question is, because it's a committee bill, it still goes on notice? We're not expected to report it the
Doesn't-
day it's,
Right, it doesn't go on notice yet, so it will be introduced. I think it will be introduced tomorrow on the floor and then placed on the calendar for action. But that wouldn't be
Right.
until
Thursday.
Thursday.
Okay. All right. That'll be fun. It's a very important bill, and thank you for all your work on this. I know that the audio only was a difficult piece, but I just want to say that this audio only is going to become sort of the pro forma use in many cases, and that we have allowed for some dialogue between the interested parties, I think is very important. And then as we go forward, I think also along this way, in this area, the alignment of how various reimbursement and how access is treated, sort of the equal alignment between and among private insurers and our public programs is very important. We know how difficult the administration of healthcare is within the physician's office or other offices. It gets just unbelievably difficult. So the more we can bring things into a line, the better off we are overall. It ultimately saves healthcare costs. And the other thing I think that is kind of is presaged a little bit in this is the the comment in the bill around contracts and having different contracts allowed for private insurance. I think that, yeah, that is important, but it's also important for us to understand that contract transparency within healthcare can allow for some alignment improvement that we may not have seen in the past. So that's an area that I've been very interested in, and I did have in a bill last year, and you may see that again in a proposal. But thank you all for good work on this bill. I don't have anything else scheduled for this morning. So,
Vacation
no.
for an hour.
So, yeah, right. So what I would ask of you is to go through and prepare yourselves for H315 tomorrow. That's the little pandemic bill, the dollars that have come to us from the House. I know there are some interests that are not included in the bill. So for me, and I think Senator Hardy has also expressed an interest in looking at long-term care a little bit. And then the other one that we've heard about in our committee is recovery, and recovery has never really been funded, but we heard some very compelling testimony about that. So just thinking that as we go through H315, keep your eyes on some of the issues that have developed as a result of COVID. Of course, mental health is huge. Our designated agencies and substance use disorder included in all of that. So just this is not the big chunk of money. It's $200 million, but we may be able to make some recommendations that improve the distribution of that funding. And I hope we can. So anything else? All right, and I know that S24 continues to be a hurdle for some of us, and I appreciate that. I appreciate folks' differences of opinion, but we will come back to that time permitting tomorrow and have a discussion and go through that bill and see where we are. And there are different possibilities for moving that bill along. So it does have to go to economic development because it came from them. And then it will ultimately go to finance because of the financial implication, the revenue implications. So just to bring us up to speed a little bit on that bill, it was always going to be a heavy lift, and it continues to be that way. But for me, it really does represent some social and racial equity issues that are concerning. So anything else? And then
You have the
S20
final
on
version,
Thursday.
so I will send it to you and to Nellie.
Excellent. And Nellie will post it. And I'll what's the next step, Jen? Why don't we close the meeting, and then Jen and I, you can just talk briefly about next steps for that. That doesn't
Sounds
make
good.
sense to. So you have some time, committee, and thanks for your good work as usual. And we finished early. That's our tradition. Let's keep at it. So Nellie, we